At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I have this great privilege of being your host for this episode of GLI Live, unpacking the EASL MASLD guidelines, and we will explain what all those letters mean to you soon. But this is such an important conversation for so many people around the world, and I am very happy and honored to have as my guest Dr. Alexander Krog, all the way from Denmark, who is also the Secretary General of the European Association for the Study of the Liver and a practicing hepatologist in Denmark, to help me lead this discussion. Dr. Krog, always a pleasure.
Thank you very much. Thank you for inviting me, Donna.
Absolutely. So I am still, glowing and smiling from our partnership in Geneva, Switzerland, around elevating liver health as a public health issue at the WHO and the World Health Association side events. And so thank you so much for your partnership on liver health and elevating it and bringing together associations and advocates from around the world in diabetes and obesity and cardiovascular disease to focus on aspects of liver health. And so these guidelines today are an example of the power of a joint collaboration, because you led with the European societies in diabetes and obesity as well. And so I might want to start with what that collaborative spirit and model of leading in medicine and in healthcare, how you feel that has enhanced this guidelines process, but also has helped to enhance our work in liver health.
Yeah, so steatotic liver disease, first of all, is a global challenge. Patients are not just in Europe, they are not just in North America, they're all over. That's again back to the collaborative effort. So of course, these are the EASL guideline based in Europe, but they are used all over the world. If you're interested to having them in your pocket, we got a wonderful app for the guideline that's for free. You can just go into Google or Apple, download it, then you got them in your pocket. But we also increasingly learning that what we did beforehand, we have to admit, again, as doctors, we always think we got it sorted out, but we tend to be very silo thinking. We also tend to be a little organ-centric. Of course, come from our research background. We cannot focus on everything at once. That's difficult. Again, if you want to understand the depth, if you go very high up, okay, you can see everything, but the detail is more difficult as you drill into it. And that's, again, we see that we take the patient's perspective just like we do. In the end of the day, we want to improve the life of patients at risk or living with liver disease, and also preventing liver disease. And that's very clear. Is this truly a liver disease only, or should we rather see this as a cardiometabolic disease? Probably, because liver disease risk doesn't go alone. It goes very closely with other cardiometabolic risk factors. Could be obesity, diabetes. And that's why we're teaming up with these societies. And again, we also learned that speaking one voice from our society together. Now you also mentioned how we work with WHO. If you're speaking against in a very noisy place where there's advocating for all kinds of other diseases or problems, if we don't speak one voice and we do it at the same time, nobody can hear us. And the same way here, we want the patients to be treated at the best and based on the best evidence, but also on how it actually can be implemented in healthcare systems. And that's why it's super important to have an alliance with the neighboring specialities. So again, obesity, diabetes, but also say the way we do these, they're also based on a Delphi consensus process. So apart from the writing group, there's been almost 50 people, again, overrepresenting in Europe, but also from all other continents, who sort of helped shape the problems or the questions. That's how it is. We start with a question and we come with an answer, which is hopefully very clear for clinical guidance.
Yes. So first of all, I want to thank you for the timeliness of the guidelines. So soon after we had an approval for medication specifically for the nomenclature is changing, but specifically for NASH was what was written in the regulatory document, and so we were receiving so many questions from patients and physicians about what to do. And so I want to thank you for getting your guidelines out on June 7th, 2024, in such representing such a nimble, but as you started to explain, a thoughtful fashion that actually started several years before, so that we as patient advocates had something very clear, very evidence-based, to refer patients to, and to be the basis for our answers and our conversations with everyone who was asking. So first of all, I want to thank you for the timeliness of that. And then I also want to thank you as a patient who has served on several guidelines committees in multiple specialties. As I read through the guidelines, I really thought that it was just a masterclass in how to present guidelines in a way that were both useful and understandable. I think we were talking before, I'm taking a course at MIT on artificial intelligence, and interpretability is the module for the week. And so how do you understand the model, the thought process that went into this? I would encourage, as everyone reads the pocket guide that you've done and the patient distillation that will be done in coordination with this episode, I would encourage not only practitioners but patients, particularly our A3 advocates, to read these guidelines as a model for how the guidelines process happens, how it can happen when it's done particularly well, and particularly when it starts with the patient, which is our motto and yours, I know, and starts with really solving a problem and then going to the intervention and comparison and outcomes. And I think it will really help people understand how you came to the answers, with also the level of evidence and where the evidence still needs to evolve. So I really just want to say it's such a, the information itself is helpful, but taking a step back and just as a model for how guidelines are done and how they're presented, to be useful for the community and societies, I just really could not be more complimentary.
Thank you very much for these kind words. Again, it doesn't come easy, but we want the guidelines. No, it is a priority to EASL. So it takes time, it costs money, and it takes significant effort to get this together. But we do believe, that's very happy for that feedback, that is actually well taken, that the way we do all the guidelines is sort of the same platform. So people can dive into it, whatever disease you're looking for, and again, see the same structure. Getting the questions, the recommendation, the statement, the level of evidence, and always down to something that should be actionable in clinical practice. And then it goes based on the panel layer, but also the Delphi panel, which is again balanced gender-wise, also distribution across the world. So we look very much, that's something we do approve actually in the governing board. So all these things, if you're not happy with them, I've been a part of approving all steps in all these things. So we do take it very seriously.
And it does get the patients included check, because patients are part of the panel and this process as well. Yes. So thank you.
No, very important to have these voices. And again, we are learning. That's again a transition for, if you did it whatever decade ago, that was not happening. We're learning that the input we get there for rephrasing the questions, for answering, it's having the right questions. It helps a lot to have patients' voices there.
So let's get into the guidelines themselves. And guidelines, I'll just mention it, are different from expert opinions, from guidances, multi-society guidelines are something that really, people can look to, and that people do look to, including regulatory agencies and others in practice. And so I really appreciate you doing the work to get them to that format. But so MASLD, as it's called, I'll let you unpack what the name of the disease is and what the definition means.
Yeah, so reason why you can always ask, why do we do a GLI? The last one we released was in 2016. Actually, a lot of things has happened. We can discuss that. But obviously, a very important milestone happened is the new nomenclature of steatotic liver disease. Basically, I think understanding the disease as an integrated part of cardiometabolic diseases and actually acknowledging that these are seen as a spectrum. That's why it's been clinically, and that's again back to the silo thinking. The world is very easy if you put everything in boxes, but the world doesn't work like that.
Right. People don't work like that.
People don't work like that, but also biology doesn't work like that. And medicine certainly not, and humans don't. And that's again, we see, okay, how can we make that? And that's why it ended up like that. And then we ended up with metabolic dysfunction associated steatotic liver disease. So that was what was formerly known as fatty liver disease or non-alcoholic fatty liver disease. And the key reason was that we know that stigmatizing wording like alcoholic or fatty just leads to lower priority, poor treatment, but also that patients, if you have a word with fatty in your disease or alcoholic, you deserve less because it's your own fault. And they're so well documented. So we don't want to be part of pushing something where our patients are treated worse or they come to later the healthcare system. So stigma cannot be underemphasized. Also at the healthcare system, at the doctor system. You also hear still politicians that are reluctant to treat diseases that are associated with behavior or lifestyle, etc. So that was really important that this was in the guideline and it was actually put together. So the point of departure there for the diagnosis, and that's again back to who should actually be assessed for this. And there you would see that people who have steatosis, which means too much fat in the liver, that can be seen by an ultrasonography or a FibroScan, or have elevated liver functions test. They might have this disease, metabolic dysfunction associated steatotic liver disease. Let's call it MASLD. It's easier to remember, and I think it's important we stick to that.
Nothing is made easier by saying it in Latin. As somebody who studied Latin in school for 2 years. And so that's often sometimes why we talk about fatty liver disease, because it does acknowledge what the actual endpoint is, that there is a dysfunctional amount, a harmful amount of fat in the liver. And as you said, there's a spectrum of severity, but also a number of different drivers of fatty liver disease.
Absolutely.
Ranging from metabolic factors like type 2 diabetes and obesity. This new nomenclature does allow for more study of alcohol as a driver alongside the metabolic functions, and allows us also to grow and find new things. So I do think that is one advantage once we explain it to people.
No, absolutely. And it's again also that, of course, obesity and too much fat in the liver is what we call liver toxicity and other mechanisms that leads to it. It's also clear that insulin resistance, early stage of type 2 diabetes are very important. But we also got what we call dyslipidemia, changes in the fat in the blood. That could be triglyceride, that could be cholesterol, what people know and many will be treated, but also hypertension. All these are strongly related and have part of the mechanism. So that's also why it's probably too simplistic just to call it fatty. We also got variant where people are lean. So where people can still have the same and be lean. So I think for understanding...
So it's not the person, it's the liver itself that has the dyslipidemia, that has the problem with the fat percentage.
Absolutely.
And that leads to scarring and inflammation and ballooning and all those terms that we learn in pathology class.
Absolutely. And then you got underneath all this the genes. Different genetic variants can also change the risk a lot. And again, if you have one risk factor or 2 or 3 or 4, it makes a big difference. And then if you add the genes, So sometimes, if you got one or two, your risk factor is not necessarily 1 + 1, but it's actually as what we call a synergistic effect. So that's again why it's important to look into all the different types of risk factors, and certainly also, as you mentioned, alcohol. That's again a thing I want to emphasize as part that has been clearly stigmatized. It's in most cultures very much taboo, that people don't talk about it. We got a lot of studies showing that many people, they tend to underestimate the alcohol consumption. And I think even if you do have type 2 diabetes and obesity, say a BMI 35, and you do drink what we say the threshold of 2 to 3 drinks today, that may be too much from your liver. And that's again to seeing this together. But of course, what is we're interested in the liver doctors, because again, we need to see it integrated to make sure that people are treating holistically. But of course, where we have a special responsibility, that's for the liver. And that's back to the scarring, as you say, that when this happens for a long time, you can have scarring. And these are the patients that should be seen by a hepatologist.
And so if, patients on the further end of the spectrum need to be seen by hepatologists, that seems to indicate to me that there are other doctors that need to weigh in as we are identifying people earlier. So what is the message to primary care, to nurse practitioners, to other types of providers who now need to sort of see liver patients as their patients too, and are needed to really address this global public health crisis?
Yeah, I'd say what we can say now. So screening in the general population, we don't have evidence there yet to suggest that. But it's clearly, if you take different risk groups, and let's say type 2 diabetes, severe obesity, these people should be assessed for steatotic liver disease. That's clear. And also, one thing is to do the liver function test, and you can see if they're elevated. There will be in many of the patients. That will again be an additional sign that something might be wrong. And then we suggest that we start off with this FIB4, which is a test that suggests, do you have a low or intermediate or a high risk of having scarring in their liver? And again, what leads to clinical disease with signs and symptoms, early premature death, need for liver transplant, what is fibrosis? So that's what these in primary care can and should do, and ask for, and also nurse practitioners when they take care of patients with diabetes. And there, among a group of patients with type 2 diabetes, maybe 2/3 or more will have too much fat in the liver. Maybe 20, 50, 22% will have scarring of the liver. So it is really important that we look into these high-risk population and assess them.
I think that's very helpful from what I hear from primary care providers, because they were like, well, everyone? I was like, no, but based on these risk factors, these are the patients that you need to, really look to identify. And then as the guidelines are so helpful and clear in identifying the sequencing of the diagnostic tests of, blood-based tests first, which everybody's getting blood work. I got blood work yesterday. Everybody's getting blood work, and then to move to imaging if the blood work is abnormal. I also noted that you're re-examining the threshold for what normal liver enzymes are. So I'll pursue that another time. But I did note that and appreciate that, because sometimes the patients have had disease confirmed in other methods, even when their liver enzymes were normal. And it's a reminder that they are not liver function tests per se, but are looking at the different tests, look at different aspects of the liver. And so I learned.
And again, that's again where the guidance come in, because you cannot expect, again, if you're a general practitioner, the next patient you may see is a patient with problem with their menopause or a newborn kid or whatever. So that's why they should have access to the guidance. They get back to our guideline app, that they should download it, because then they got in the okay, what is it that EASL and the society suggest we do here? How do we actually make sure the knowledge we have and the treatment recommendations we have, they benefit my patients? And that's really the purpose of having these guidelines, to bring an relatively easy way for people actually to do something as best as possible.
I appreciate that you mentioned, treating, menopausal, age women. I noted that one of the things that the Obesity Society brought in was a million woman study. There are considerations for people with PCOS, and you really sort of as a woman, I really appreciate it. And as somebody who has worked with the Society of Women's Health Research and others about gender-based medicine, I really appreciated and noticed that you took the time to be thorough, to think about how the set of conditions, the spectrum of conditions, plays out in women sort of across their life cycle and at different hormonal stages and intersections with different conditions. So thank you for that. And also you noted different ethnicities, and then so there are aspects, general aspects to this, but then you really drilled down and thought about it for different populations. So please.
No, it's again important there to understand. You say that different risk based on the race. So again, that's also something you should take into account. And you say there's also, as you say, linking postmenopausal women are also at higher risk. And there's again the link there put to PCOS. And again, something we should acknowledge. Again, back to seeing as a part of the syndrome. Okay, do you have a younger person who cannot get kids even though they want? Okay, consider this. Okay, do you ask about their sleep? Sleep apnea is very frequent in these patients, that we really try to bring this holistic. And if you sleep back, there's also a strong association with poor diet, or you sleep little, etc. So there's some of these things where you can sort of bring it all together if you want. And even though you're specialized in one area, some of these things with treating the other things is not very difficult, actually. Of course, all of us who are background internal medicine, of course, we can treat hypertension. We can do most of the things in type 2 diabetes, etc. So we say holistic or integrated care. And sometimes when we draw the diagram, we want all kinds of specialists, and that may also be perfect if you can make it work. But in most places, the healthcare system, this is not necessarily possible to have all these specialists available for one patient. But MASLD said, okay, if you got the ideal center, you got access to this. This is beautiful. And then they should come together so the patient don't need to go to 10 different places, because then they get confused. But if you don't have it, I think the individual doctor who do read what we do and read the suggestions, they can do 90% of this just perfect.
Absolutely.
There's no excuse.
I had my hematologist actually where I was yesterday, and I was kicked out for being too healthy. I'm glad to say, but they took the time to ask, have you talked to your nephrologist, and you're being followed by a gastroenterologist? I'm like, oh yes, closely, for someone like me. And we went through the list, by system, so that I did feel like that there was whole person care. And so they could have just stopped at, your hemoglobin is in 2 digits. And so we're happy with that. But they really just took a few, an extra minute or two just to make sure that I was on track with the other things that would actually, factor in to my overall, wellness. And I really appreciated that. And I also appreciate how your guidelines at least acknowledge that not everyone may be at a well-resourced center with all these different parts, and that they would be adapted for different, resources and in other ways. And so I thought that was a really important acknowledgement, and why there's such a great, global appreciation, applicability of your guidelines.
Yeah, there is a strong association in our countries or regions, but also outside, to socioeconomic factors.
Yes.
And that has been again repeated. That's again the society. If you look in your country, but those people who don't do very well, they can only afford poor food or bad food, and they're not necessarily educated in really understanding the association between behavior and things that leads to increased risks. So that's another real challenge. I think many of us, like you and me, we're kind of privileged because we well educated, we got a healthcare system that really worked for us, and then we still need to find a way to make sure that these people with less resources, but also a certain level of neglectance or healthcare avoidance, etc., that we bring them forward and actually also help them. And that's again, I say, yes, we can make the best of the best system, and that's fine. You want to do that because that will lift all the other system. But as you also say, okay, what can you actually do with what we have and with relatively cheap drugs? What can you do with yourself? And that's also what we got a lot of guidance there. How do you manage the weight issue? How do you manage diet, etc.? What can people actually do themselves? That's also what many are looking for.
Right.
Of course, there are people who would like to have, let's say, help from a drug or shortcut or whatever, and that's of course very important for many of these things. But also people who need the guidance. And in essence, you should do it all, and then have an alliance with your patients. How can you actually make it work?
We talk about controlling the controllable. And so certainly, as I am asked the question, how am I doing so well 30 years, almost 30 years in a few weeks, post liver transplant, God willing, is because I have tried to do what I can do, what's in my power to do in terms of exercise and eating, and trying to, make as many doctor's appointments as tests as I can and still, live my life and do my work. But there's still then medications that I take every day. And, there's only so much that is in that controllable bucket. And I think those two need to go together. And certainly, patients with MASLD have often tried to lose weight in so many ways, and have tried so many things. And so come to this place where they need, either structured support, or you mentioned, bariatric surgery as an option, and, where approved, various drugs that are for, weight loss or specifically for MASLD now being evaluated, in Europe, like it has been in the United States, and to be, continued hopefully and for other areas of the world. But I think that it is the combination of these factors, of the science and the community and individual work, that gives people so much hope now in 2024 than they've had in the past, where there was sort of only, lose weight, good luck.
And we know we didn't know it didn't work. There are hundreds of studies that most people in the studies, when they're taken very good care of by a wonderful research team, can lose weight, but they all gained it again. I'm fully, that's again also what we write very clearly. They are the diet things, they should go together with. But today, we witnessed a revolution actually. Before, you shouldn't go too many years back, obesity was just untreatable and it was just growing. I don't know, in my country, you is probably saying 50% of the population is obese with a BMI above 25, and whatever 20% or more above 35. They're really at high risk. And of course, where applicable, and depending on what is the reimbursement, of course, these should be offered the treatment. In particular, if they also have type 2 diabetes, because these treatment, you can see now with documentation, they reduce the weight. It makes them just function much better because they are lighter. It takes the diabetes, protects the kidney, protects all kinds of things. So these drugs are just effective and should be implemented when people can access. And some also, that's also we write about, what is the role of bariatric surgery? There are still people where this is a very good option because you have the surgery, of course, but you don't need to take a drug for the rest of your life. And of course, there is an issue with a drug. When do you start it? Do you remember to take it? Can you afford it? Well, are you ready to take the rest of your life? And that's again the balance. And that's back to the discussion we have. Really, the doctor-patient relationship is super important here. And when possible, empowering, educating patients, because then you can really do a lot of things. If you got this trust and you have patients who can really learn and are interested in this, it's amazing. And then they come and show me a lot of things. If I read this and seen that and what works, and that's a discussion. And then, of course, there are people who have more challenging situations in life you need to treat a little bit differently. But I think we are really witnesses in a dramatic change here. So the whole metabolic field, type 2 diabetes, but also see with the first drug now approved, resmetirom, approved in the United States, and we hope we'll get to Europe. And that's the first drug. We will expect whatever in 5 years, hopefully we will have 1 or 2 drugs more, and there are several in the pipeline. So we're looking into a future where this disease is treatable, preventable, And of course, there we should gear the healthcare system. That's another thing I want to point out before we come to an end here, that actually we historically we used liver biopsies a lot. We also done that in the clinical trials. But now the revolution in also how we use non-invasive tests, the test that does not take that you need to take a liver biopsy, can tell you a lot about your diagnosis, but also your prognosis. So basically tell you how damaged is your liver, but also what is your risk of leading to clinical liver disease in the future? What is actually basically your need for treatment? And that's, I think it's really interesting also to see that FDA really embraced that and approved resmetirom without the need for a liver biopsy. And then,
As
of
someone
course,
who's had 6 liver biopsies, I really appreciated that part. And as the evolution of non-invasive tests has risen just along with the drug development, it's been so exciting to see. And certainly as a patient, so thought of very patient-centered, and how we would scale to be able to meet the challenge of the number of people who do have MASLD. We can't do it with the, linked to biopsy.
No, and that's again back to the primary care. We need to have these simple tests. I mentioned FIB4, but there's also an involvement in tests. So what specific test? Now we recommend this, but it's more basically to understand the trajectory, that the patient should be the right place in the healthcare system at the right time. And research should help develop these tools and implement the healthcare system a little different. You might want to have a little bit different here or there, and how to also avoid scaring people. That's another issue. You got a lot of people who say, okay, you do have risk, but for now you shouldn't worry so much. You go back to your general practitioner, you do this and this and this, then we reassess in 3 or 5 years. Or you go to a hepatologist. Okay, what is your risk? What treatment can we offer you? How will we know if it's actually working in a year or two? So all these questions, we try to have a framework, but still it's evolving. And I think really the future is bright for this field and for our patients.
Well, I'm excited that we are evolving it together. And so thank you so much for these guidelines to ground us, and this partnership to give us wings. Thank you so much, Alexander.
Thank you very much, Donna.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.